Hello, my name is Professor Dave Smith. I'm a cardiologist in Swansea in the United Kingdom, and I'd like to welcome you to this Abbott-supported webinar. Today, we're going to be discussing how we should reduce paravalvular leak in our patients undergoing TAVI. And I'd like to hand over to my colleague, Michael Lee from Hong Kong, to take you through the agenda and the learning objectives.
Thank you, Dave. My name is Michael Lee from Hong Kong. Today, we have two distinguished speakers, and they are Professor Dave Smith from the United Kingdom, Swansea, and Dr. Anthony Camillia from Brisbane, Australia. So today's learning objectives are to discuss how paravalvular leak impacts the clinical outcome for the patient, and to discuss novel sealing technology in a next generation transcatheter heart valve, and to learn how to reduce paravalvular leak by optimizing procedural steps. You have the chat function in which you can actually type in your questions. We'll try to answer your questions one by one. Without further ado, I would like to invite Dr. Anthony Camillia to give his first talk. Anthony, please.
Many thanks, Dr. Lee and Professor Smith. Thank you so much for involving me in this webinar this evening. This is an exciting topic and a piece of technology that I think is on the precipice of taking TAVI another stride forward in terms of its evolution as a treatment and technology for patients. My disclosures. So let's start with paravalvular leak. In the early days of transcatheter aortic valve replacement, when things were just getting going, paravalvular leak of moderate or more severity was actually relatively common. And the initial thoughts were, well, moderate aortic regurgitation in people walking around in the community is not really a problem. It rarely causes symptoms. Often the duration of onset of regurgitation to progression to more significant insufficiency and heart failure is years, if not decades. And there wasn't much thought actually given to paravalvular leak in the early days. Subsequently, a very consistent signal became evident from the earliest large cohorts of TAVI patients, both single-arm studies and randomized controlled trials, that paravalvular regurgitation was not a good thing, that paravalvular regurgitation was almost in a dose-dependent manner associated with worse outcomes for patients, with higher rates of rehospitalization, significantly higher rates in multiple data sets of endocarditis, and a clear, reproducible, time and time again message that paravalvular leak independently predicts increased rates of mortality at 12 months and beyond. And I think all of us in clinical practice who've been doing this for some time now can recall patients across the years who had moderate or worse paravalvular regurgitation. And the data would tell us that about half of those patients are really going to struggle to get to 1 to 2, maybe 3 years without significant progressive heart failure or death. Now, we thought those, and it is purported that those sentiments and observations have almost been obliterated with the current technology available, but that is not the case. The most recent data we have around this in a real-world setting is the SAPIEN 3 Partner 2 registry cohort, which were patients at intermediate risk and represent real-world patients in most Western countries, patients around 80 years old with significant aortic stenosis who were not suitable for inclusion in randomized controlled trials and were treated with a balloon expandable system. And in that real-world cohort, 1 in 30 patients treated with an Edwards SAPIEN 3 had moderate or more paravalvular leak, and 1 in 3 patients had mild or more paravalvular leak. And this is important because in that same cohort of patients, we see that death or rehospitalisation at 12 months, and this data has subsequently been taken out to 2 years in a subsequent publication in Neurointervention, is approaching 40% for death and rehospitalisation, as well as mortality being a clear signal in this data set. We have also seen in larger follow-up of patients in registry series, the FinValve registry, which is pretty meticulous about how they follow up their patients. Interestingly, we saw a dose-dependent effect on the degree of mitral, the degree of aortic insufficiency, paravalvular leak, leading to increased mortality. So this seems like a pretty consistent message. And second from that, the current generation of technology available, the most the contemporary, well-published balloon expandable systems as well as self-expandable systems have not cracked this egg. Paravalvular leak is still a problem, and it has a potential for significant harm and poor outcomes for our patients. The Navitor system is a significant step forward. So the Navitor system is not just Portico with a different name. The Navitor system has had significant engineering improvements performed in order to mitigate paravalvular leak, improve deliverability, while maintaining excellent effective orifice areas and maximising flow through the left ventricular outflow tract with minimal gradient. Key to this is a flexible delivery system with simple preparation, no need to check for funny hat markers and stuff under X-ray, which kind of gets pretty annoying and time-consuming. There's a reverse parachute Navisil cuff that elegantly and atraumatically fills in the potential spaces for paravalvular leak, which billows during diastole, and over time has tissue ingrowth and healing that, in combination with the conformability and increased radial strength, especially in the 23 and 25 sizes of this system, have led to significant mitigation of paravalvular leak. This is while maintaining an intra-annular valve leaflet design with large cell geometry, and the large cell geometry does two things. The first thing is it maximizes coronary reaccess when combined with the intra-annular leaflet design. And the second thing is that the large cells allow for nestling of calcium nodules between the frame struts to minimize paravalvular leak. As stated, the FlexNav delivery system is an improvement on the previous delivery system while maintaining the lowest profile of any of the major vendors in terms of system delivery, with 14 French and 15 French systems respectively for the different sizes, which is flexible, stable, and highly deliverable around all anatomies. So we've reviewed the design improvements. Let's focus down on some of them now. So the radial force of the system has been optimized. In particular, the smaller sizes, 23 and 25, have had improvements in their optimal force with a change, with subtle changes in the material and mechanical engineering components of the system. The tops of the frames have been turned inwards to reduce potential trauma to the aorta. Large cell geometry allows for nestling of calcium nodules in the outflow tract and annulus. There's a fabric inner cuff, which in combination with the Navisil polyethylene fabric outer cuff billowing reverse parachute system, mitigates and in most cases obliterates paravalvular leak. And the paravalvular leak reduction is a combination, as I said, of the mechanical factors as well as tissue ingrowth, as the diastolic billowing of the system allows. So if we take a common scenario that we all face in clinical practice, and that is annular calcium and LVOT calcification. Now, we need to talk about real-world patients. As you all know, there have been low-risk studies performed on patients who are much younger than what we typically seeing, and the technology is moving to the treatment of those patients. But we have to be careful about interpreting the paravalvular leak data from those studies. If we take the Partner 3 study, for example, we know that 1,520 patients were screened for that study and had their cases put before the screening committee, and 520 of those patients, so a solid third, were screen failed. And as is documented in the supplementary appendix to the manuscript for that study, the most common reason for screen fail was calcification in the outflow tract and annulus. Now, in the real world, we can't screen fail a third of patients, and we have to treat them. And so a technology that in clinical trials screen fails a third of patients isn't something that we can translate into the real world, and perhaps explains what we saw earlier when I showed you the Partner 2 cohort data regarding the rates of paravalvular leak in real-world patients. So we are then left with potential options. A balloon expandable system, even with the skirt, is not able to address the paravalvular leak issue. If you keep expanding that balloon expandable valve, which traumatizes the annulus as it circularizes it, you either are left with paravalvular leak or you get root rupture. So you can't do that. Self-expanding supraannular systems, well, they've got the issues of a high supraannular system, small cell geometry, which impairs coronary reaccess, and no true billowing reverse parachute Navisil type sealing system that the Navitor has. And if we look at Navitor, it really addresses all the issues. We've got large cell geometry, coronary reaccess, and a system that's been engineered to mitigate paravalvular leak. So when we look at these valves on CT, we see that they conform to the annulus. We see that they can adapt to elliptical geometries with maintenance of leaflet function. The bovine pericardial leaflet tissue with anti-calcification treatment has been trialled through more than 200 million cycles in elliptical geometries as well as circular geometries, and leaflet integrity and durability has been demonstrated in those settings. We are then able to combine that with the data that we've seen using the cusp overlay technique to try and maximize our implant height. So the combination of this engineering step forward with all the improvements that have been integrated from the iterative learnings of TAVI over the years into the Navitor system, which brings all of this knowledge together into one system, then combined with the most up-to-date techniques to maximize implant height to minimize permanent pacemaker requirement. The cusp overlay technique, which allows us to elongate the outflow tract and position a prosthesis 2 to 3 millimeters below the non-coronary cusp insertion point, even in horizontal aortas with a vertical annulus. During deployment and delivery, a stable system with good hemodynamics due to the intraannular leaflet design with early leaflet function and avoidance of loss of cardiac output and avoidance of rapid pacing in order to deploy the system. And even initially before the ongoing reduction in PVL that occurs over the next 3 to 6 months, we are seeing very low levels of paravalvular leak. And Professor Smith is going to talk about that in more detail when he discusses some of the results from the Navitor studies. So, really in summary, this is exciting time for our patients. I think we finally have a technology that we can look in the mirror and honestly start to say is comparable to open surgery in terms of the Achilles heel of paravalvular leak. Paravalvular leak is something we need to take seriously, and we need to have rates of paravalvular leak as close to zero as possible because of the deleterious effect it has on our patients. So we've now been able to integrate that technology into one system, and the Abbott Navitor system really allows for some exciting times ahead in our field of medicine.
Well, thank you, Anthony. That's a fantastic overview of the Navitor system. Next, we'll have Professor Dave Smith to show us a case in the box.
Thanks very much, Michael. So I'm going to show you a Navitor case from my hospital. So just to reiterate what Anthony has said from that excellent overview, this is a final iteration of a journey with the Portico system, from not only changing the delivery system to make the delivery system enable valves to be implanted more predictably, more accurately, but now an addition to an enhanced valve with the features that Anthony has already described. We're talking about PVL today, so we're really interested in the Navisil cuff and how that works to manage and reduce paravalvular leak. And as you've heard, it is a diastolic reverse parachute, if you like, so active sealing of any gaps in the annulus between the frame in diastole. And if you look at the video that's playing here, so this is, if you like, a left ventricular view of the Navitor in place in a model, and you can see that whatever the orientation elliptically or circularly for the Navitor valve, you can see how these gaps are being filled in diastole by the Navisil cuff, and that is according to the multiple iterations of permutations, if you like, of the shape of the annulus that the model is trying to recreate there. So models are very good, but let's look at the real thing itself. So I'll introduce you to the case. This is an 87-year-old female, STS score of 5.1 and a EURA score of 3.1%. So a very high-risk patient, but certainly in my population, a patient that we see very frequently. Luckily, the ejection fraction is preserved. The valve area is low, and as you can see from the Doppler trace, the gradients are high, confirming severe aortic stenosis. Just to drill down a little bit more deeply into the CT findings here, you can see that the valve itself is moderately calcified. There's significant calcification on 2 of the 3 leaflets. There's some patchy calcification to the aortic arch. Fortunately, the aortic anatomy is not that tortuous, but perhaps a typical elderly, high-risk TAVI patient. Pleasingly, the iliofemoral access was good, large caliber, non-tortuous iliofemoral arteries, thus allowing transfemoral TAVI to be performed. So our plan in this case, after sizing the valve, was to perform a 27mm Navitor valve implant under local anesthesia, ultrasound vascular guidance, a 15 French femoral sheath with ProGlide pre-closure, and pre-dilatation with a 20mm pre-dilatation semi-compliant balloon. So you'll see this is the balloon valvuloplasty with a 20mm balloon. It's uncomplicated. And you'll notice that this is in the 3-cusp view. Anthony talked about the cusp overlay views that we're all becoming increasingly acquainted with. This is a balloon angioplasty, balloon valvuloplasty rather, in a 3-cusp view. So you'll now notice we switch to an ariocaudal view for right-left cusp overlap, and you'll see the starting blood pressure of the patient. And this is the setup aortogram to initially locate the Navitor valve in the location we wish it to be for the duration of the procedure. You will now see real time the valve being slowly but steadily unsheathed. There's no rapid pacing. The blood pressure remained unchanged. And you can see it's a very stable delivery where both the operators have very little to do in terms of maintaining the position of the Navitor valve. And as Anthony's already said, because the leaflets are in an intra-annular location, we get early functioning of the leaflets. For the majority of patients, a very hemodynamically stable procedure, which is very nice for the patients not to lose cardiac output, and certainly very nice for the operators to make the case very simple and straightforward. Once we have the valve at the so-called lock point, at which point it is still fully resheathable and retrievable, we perform an aortogram, as we would normally do, to check on the position of the valve, to check that we're happy. We can see that the valve is in a good position, the delivery system is neutral in the mid-aorta, and the blood pressure has remained unchanged for this patient, in keeping with the hemodynamically stable procedures that intra-annular leaflet design provides for. Now we come to the valve release, and again, this is a very straightforward and simple thing to do. You can see this slow but steady release of the valve frame from the delivery catheter. And as Anthony's already said, the new inward curvature of the proximal end of the valve frame allows for an even easier release from the delivery catheter. You can see we will then check our position as per usual practice with aortography, hemodynamic assessment, as well as echocardiography. And you can see already, even with the presence of a stiff pre-shaped guide wire across the valve, we still have no paravalvular leak. We will then perform our closure as planned with the ProGlide pre-closure, and you can see the digital subtraction angiography confirming that in this case, with a 15 French inner diameter catheter, we have no vascular complications, and pleasingly for the patient, this patient will be able to be ambulated very quickly. In terms of this particular patient, the patient had a peak gradient of 12 millimeters of mercury, a mean gradient of 7 millimeters of mercury, and no aortic regurgitation. Also, pleasingly, from the valve position, the PR and QR intervals were unchanged, therefore indicating no new conduction abnormality caused during this case. So, having shown you a case in a box from my institution, I'm now going to go on to just show you the 30-day outcomes from the Navitor valve that were presented by my colleague Lars Sondergaard at EuroPCR in the spring of this year. So this was a multi-international site study, Australia, Europe, as well as the United States. And essentially, patients were enrolled if they had severe symptomatic aortic stenosis and were either at high or extreme surgical risk. I'm presenting you the 30-day data, but follow-up will continue for 5 years and will be presented once that milestone has been reached. The primary endpoints for the study were all-cause mortality at 30 days and moderate or greater paravalvular leak at 30 days. There are also a number of descriptive endpoints based on the FARC2 criteria. So clinical events at 30 days, together with valve hemodynamics and paravalvular leak, both at discharge and at 30 days, together with symptomatic change and functional assessment at baseline as well as 30 days. So if you look at the demographics of these first 120 patients, 83.5 years, an elderly group, their STS score was 4.0%, therefore a high-risk population. Their low valve areas and high mean gradients confirm the diagnosis of severe aortic stenosis, and you can see that nearly 85% of the whole patient population had at least one frailty factor with a number of important comorbidities, in keeping with the risk classification of this population. If we look at the procedural outcomes, all patients received a valve, no procedural deaths or conversion to open surgery. 3 patients required an additional Navitor, and that was either because of movement of the valve upon post-dilatation, or potential malposition of the first device. If you look at the 30-day outcomes, there are no deaths at 30 days. One patient had a stroke, 2.5% of patients had life-threatening bleeding, and 15% of people had a new pacemaker. But it should be noted that of these 16 patients, 13 of these patients already had pre-existing conduction abnormalities, in keeping with the high-risk nature of this population. Now, these are probably some of the most striking outcomes in terms of the Navitor valve itself. The valve hemodynamics show very high effective orifice areas and low mean gradients, both at discharge and improving yet further out to 30 days. Strikingly, in terms of paravalvular leak, 1 in 5 patients had only mild paravalvular leak, whereas the majority of the patients, 80%, had either no or trace paravalvular leak. Therefore, nobody had moderate or greater paravalvular leak, and therefore these results would place this valve in the leader of all of the commercially available valves at the current time. In terms of symptomatic classification, you can see that 97% of patients either in class 1 or class 2 MYHA classification, and you can also see that their functional assessment of a 6-minute walk test has also improved by an average of 21 meters from baseline to 30 days. So the conclusions we reached in this presentation back early in the spring of this year were that there were low rates of clinical events, demonstrating that the Navitor valve offers a very safe option for patients at high or extreme surgical risk. The large effective orifice areas and the low mean gradients indicate very favorable hemodynamics, and the absence of any moderate or greater paravalvular leak and the low rate of mild paravalvular leak suggests that this active Navisil sealing cuff is a very effective design to mitigate against paravalvular leak. In terms of future patient considerations, we already have some very interesting data comparing Portico Navitor now with both the Evolute supraannular leaflet location system and the Sapien balloon expandable system. So if you look at the diagram on the left, you can see the comparison of Navitor versus Evolute, and you can see that an intraannular leaflet location design valve is identical in its hemodynamics with respect to effective orifice area as well as mean gradient. But when we compare hemodynamics versus the balloon expandable Sapien system, you can see that the Portico system has higher effective orifice areas and lower mean gradients, very effective hemodynamics. Thank you very much.
Thank you, Dave. That's an excellently performed case with very good results and very good outcomes from the Navitor first 30-day outcome trial. Now we are open the session to questions. Please type in your questions in the chat box if you have any questions, and we'll try to answer them one by one. Maybe I can start with Anthony. Anthony, you mentioned about the calcium in the annulus that actually the Navitor valve is designed for. You know, in Asia, we have particularly calcified aortic valves, especially at the annulus valve area, as well as a lot of bicuspid valve. So do you think the Navitor valve has advantage to tackle this sort of very calcified aortic annulus?
Thank you for the question. And I've had the opportunity and great fortune to have worked with colleagues around the Asia Pacific region. Yes, outside of Australia, further north, I was blown away by the challenging anatomy. your operator's face. That is another page in the book of TAVI, really. Not only do you face patients with bicuspid anatomies in all age groups, right up into old age, tortuous small access is a frequent partner of the smaller body profiles of a lot of your patients, and annular calcium and eccentric annular calcium in particular. The Navitor valve really offers a lot of potential solutions in that patient population. In terms of deliverability and access, the system is truly 14 French for the 23-25, 15 French for the 27-29, with an inline sheath type system that's extremely deliverable and flexible when compared to other self-expanding systems. And when you add into that the inner and outer cuff, the Navisil reverse parachute billow, you potentially now have a system that can predictably treat patients with smaller roots, calcified annulus. No trade-off in terms of increased diameters of the delivery system as a cost for the paravalvular leak mitigating technology. The size of the delivery system is unchanged from the previous versions or the previous unimproved versions of the valve. And the benefits of having a system with a proper, true paravalvular leak technology, not just a wrap that we see on some of the other self-expanding supraannular systems, but not the trauma of a balloon expandable deployment that traumatically circularizes the annulus with significant risk. And finally, superior effective orifice area compared with balloon expandable systems that we've seen in multiple studies now.
Great. Dave, can I address the second question to you? You mentioned about very optimal, very low PVL rate in the 30-day outcome Navitor trial. It's only like mild PVL in 20%, and then 80% with trace or non-PVL at all. So what are the patient subsets? Are they with very calcified valve so that you can achieve this good result, or the annulus are actually not that calcified?
Yeah, thank you, Mike. It's a very good question. I think it's important to emphasize that the data that we presented there was derived from high and extreme risk patients. So in that cohort of patients, we actually had some very calcified anatomy to deal with. So we weren't dealing with a young population, we were dealing with patients who were older, and therefore if you looked at the annuli that we were implanting Navitor into, these were challenging calcific aortic annuli. But despite that, we've achieved these results, and I think it's very important to emphasize that. If I look at my practice and my patient population from the Navitor trial, again, elderly, complex aortic annular anatomy, and despite that, what we were also seeing very pleasingly was this was an on-table seal. This wasn't waiting for pre-discharge testing to confirm no paravalvular leak or trace paravalvular leak. This was happening at the time of the implant. So we were seeing a very rapid and gratifying reduction of paravalvular leak and annular sealing by the end of the procedure, not by discharge or by 30 days. This was very, very reassuring. So in my practice, I think that, as Anthony's pointed out, there are two factors to this. I think one is the conformability of the valve frame. Less metal, larger cell size enables the valve frame to conform better to the annulus that it's being implanted into. When you then add in the Navisil technology that we've described today, that is our secondary benefit in terms of annular sealing. And the combination of frame design plus Navisil design is what I think is providing an excellent paravalvular leak reducing technology with this valve?
Great. While we are still on calcification, there's a question in the chat box. In a patient with heavy calcification, would you go for a more aggressive pre-dilatation with a bigger balloon, or start with a more conservative approach and maybe post-dilate later? Maybe Dave, you can help to answer this question since you've shown a case with pre-dilatation.
Yeah, it's a very, very good question. I liken the preparation of annuli to the preparation of coronary arteries before stent placement. If we had a calcified coronary artery, we wouldn't simply directly implant a stent. And I think the same is true for transcatheter heart valves. Clearly, the more calcified the annular anatomy, which is judged by your CT, the greater we have to pre-dilate and prepare the annulus for valve implantation. So yes, I think that the design of the Portico valve lends itself for pre-dilatation. I will normally pre-dilate the valve, and I will normally size my balloon on the minimal diameter that I've derived from the CT. However, if the valve were very calcified, I might extend that to the mean diameter of the annulus on CT, and also upscale my balloon from a semi-compliant balloon, which is my standard pre-dilatation balloon, to a non-compliant balloon. But I think it needs to be individualized to the anatomy that you find on the CT. And I've no doubt that preparation of the annulus before valve implant is key.
Great. Anthony, a question in the chat box. You show us that the radial force actually was improved. So in the presence of severe calcification and trying to aim at high implant, could the valve embolize, like slide to the aortic side due to the presence of the sealing skirt?
Yeah, thank you for the question. If the valve and the delivery system is used as per the instructions for use, which is aiming for a deployment of about 3 millimeters below the non-coronary cusp insertion point or 3 millimeters below the annulus, and taking advantage of the fact that the intra-annular leaflet design means that there is leaflet function almost straight away, so that there is not a loss of cardiac output. There's no need to rush. There is no reason to use rapid ventricular pacing. Then one can take their time to deploy the valve at that position. I think this valve is designed to be implanted at 2 or 3 millimeters, not at 0. The system is much more deliverable and much more flexible than supraannular self-expanding systems. Those systems have a higher opening force. So Evolut, for example, due to the nature of the metallic alloy, and the small cell design, the opening force of that system is greater, but the final radial force between Navitor and those other supraannular systems is actually about the same, the final radial force. So when this valve is delivered and deployed as it's supposed to be, then no, that's not an issue. Separate from that, the Navisil skirt itself does not lead to problems with pop-out or translational motion. I think if this valve is attempted to be deployed in the recipe book fashion that some of the other self-expanding valves seem to work pretty well with, so the recipe description of the cusp overlay technique using a Lundquist wire aiming for a 0 to 1 implant, I'm not sure that part of the cusp overlay technique should be translated to this valve. I think we aim for 2 to 3 millimeters, take full advantage of the Navisil system for reducing PVL, and then if needed, some post-dilatation can be considered. But again, because the Navisil skirt is there, we can reduce the aggressiveness of the post-dilatation that we need to do, because the Navisil skirt will mitigate paravalvular leak.
And Dave, in case of leaving behind a moderate PVL, is it safe, or is there an indication to perform post balloon dilatation?
Yeah, it's a good question. Yes, there is always an indication to perform post dilatation if you don't have the result that you desire. My personal experience with Navitor is that provided your preparation is good, with a good pre-dilatation, it minimizes the need for post-dilatation. However, that's not to say I don't post-dilate Navitor valves. I do if I do have residual paravalvular leak following my Navitor deployment, but certainly the post-dilatation is something I would consider to further optimize my result should I need to.
And to follow up on that, what kind of calcification pattern would it render the team becoming less aggressive in terms of post-dilatation for fear of aortic root rupture? Do you ever fear of that?
Yeah, again, it's a very good question, isn't it? I think that certainly we know from our early days that when we have calcium that extends beyond the annulus into the left ventricular outflow tract, into the top of the sinuses of Valsalva, we know that those patients are at increased risk of rupture, be that within the left ventricle itself, or at the annular level, or at the sinutubular level as well. So certainly, when patients have calcification that extends beyond the level of the annulus, then those people, I don't want to turn my self-expanding valve procedure into a balloon expandable valve procedure. And after all, that might be one of the reasons why we've chosen self-expanding technology over balloon expandable technology in the first place.
If I could just add on there, I think that's a very important point. With the self-expanding valves before Navitor, there was nothing like this Navisil system. This is not just an extra wrap around the outside. It's a polyethylene cuff that billows out and falls into the potential paravalvular spaces during diastole. And over time, there's tissue ingrowth that actually allows healing in combination with the conformability of the frame. So this is changing the way we have to address the risk of paravalvular leak. I think the first thing is that when you use this system, the amount of paravalvular leak that triggers you to have to do aggressive post-dilatation just seems not to happen very much, if at all. We enrolled 14 or 15 patients at our centre in Brisbane in the Navitor study, and they were real-world patients. The screening committee did not knock back patients with annular calcium. That wasn't a feature. If anything, they knocked back patients that they felt were too low risk to include in the study because it was a high-risk study. So these were real-world patients, generally between 80 and 85 years of age, with all sorts of anatomy, including annular calcium and aggressive post-dilatation, like we still have to do with some of the other self-expanding systems in an effort to try, and what is often futile, to reduce paravalvular leak when there's a calcium nodule. I think the engineering in this system really addresses a lot of those things, and you should find yourself not needing to do those high-risk, aggressive post-dilatations.
And to write on that, Anthony, you're showing us that the Navitor valve actually can adapt to even an elliptical anatomy. So the question is, what do you think of this non-circular geometry? Will this influence the valve lifetime?
I might defer to Professor Smith on that question. The data that we've got, and from Portico, we're not seeing an early signal here of, we're now, I don't know how many years down the track we are with the Portico studies. And those of us who are implanting Portico for over 5 years before Navitor, we're not seeing patients with early failure. We're now getting out beyond 5 years. The sort of engineering mechanical testing has been done up to 200 million cycles in all geometries, including elliptical geometries. And again, didn't seem to be a signal for leaflet degeneration because of an elliptical conformation. But I'll defer to Professor Smith if he's got any other insights there.
Yeah, it's a very good question, isn't it? We know that aortic annuli are elliptical. The idea of a circular annulus is nonsense, really, isn't it? The valve has been designed to function in multiple elliptical geometries, as I showed in the model, I guess, really, not just the Navitor, but the original Portico valve. Many valves will have central aortic regurgitation when you have very elliptical annuli. The Portico and now the Navitor valve was designed to function well in all forms of elliptical annuli. When we look at the data both for hemodynamics in the short term and hemodynamics in the long term, that's borne out by the data. This is an excellent hemodynamically functioning valve. And as I alluded to in my slide, I think it also blows open the myth that had been long purported that supraannular technology produces hemodynamically superior results. We saw from the randomized IDE study from the United States that I presented a single slide of, that the comparison between a supraannular valve hemodynamics and an intraannular Portico valve hemodynamics were identical. There's no difference in hemodynamics between supraannular and intraannular hemodynamics. And clearly for patient longevity, valve durability, that's a very, very important factor for the long-term well-being of our patients. And certainly in my practice now, we're out to beyond 5 years with our Portico experience and follow-up, and we are not seeing hemodynamic deterioration for these patients. We still see excellent hemodynamics 5 years out from original implant.
And Dave, we saw in the trial that the new pacemaker implantation rate was still 15%. Was it because of those patients are really too high risk, too sick, or the cups overlap technique has not been systematically used throughout the trial?
Yeah, it's a very, very good question and one I often get asked. So 2 parts to answer that question. You have to look at the population in whom these valves were implanted. The high extreme risk population. These people, aside of TAVI, have a risk of requiring pacing. When we looked at the data itself, as I said, 13 out of the 16 people who required a pacemaker already had conduction disease. The trial did not mandate prior pacemaker implant to TAVI procedure. If I look at my own practice with Portico over the last 5 years, we have a single-digit pacemaker rate. In my institution, my overall pacing rate for all comers is between 7 and 8%. Ironically, in my hands, the pacing rate for Portico and now Navitor is lower than that for Sapien, which has been long regarded as the lowest pacemaker device in the transcatheter heart family. Your last point, I think, is also very opportune about cusp overlay. I think that when I certainly go to other cath labs, both in my own country and abroad, I see that there's still a variable take-up of the cusp overlap technique to make sure that we're implanting transcatheter heart valves, whatever the type of valve, in the location that we want to be implanting it. And I think with wider application of cusp overlap, that we will see a continued fall in pacemaker rates. But certainly that is a challenge for the whole of the TAVI community to make sure that we're optimizing implants wherever possible to lower pacemaker rates. But certainly from my practice, I've not seen for the last now 3 to 4 years a double-digit pacing rate with any of the transcatheter valves, and that includes Portico, and now that includes Navitor.
Great. And Anthony, when we talk about lifetime management for lower risk younger patients, we often think about durability, coronary access, future valve-in-valve. So do you think the Navitor valve is actually more advantageous as compared to other self-expanding valve, or even when compared to the balloon expandable valves?
Yeah, thank you for that question. I think we have to be very careful with low risk. I think we need to give a lot of thought to how we manage patients across their lifetime. And when we talk about low risk, what's low risk? I think the concept that you raised, Dr. Lee, about thinking about a journey is probably a good one. And it's very individualized on what patients require. Certainly, out of the technology that's available, Navitor is really very favorable. It offers an intraannular leaflet design, coronary access, excellent hemodynamics. However, in patients who are truly low risk, and in my mind, truly low risk is a patient who's generally under 70, who's in their 60s or lower. I think we have to be very careful about how aggressive we are with TAVI versus surgical AVR for those patients. We are probably, if we're being completely honest with ourselves, seeing results that are equivalent to surgical sort of results from good surgeons in that Navitor data that Professor Smith presented. I don't think we can read too much. Partner 3, for example, 520 patients out of 1,520 who were screened were excluded, mainly because they were concerned about unfavorable outcomes, predominantly in the patients if they were randomized to transcatheter valve replacement. So it's very hard to take a study that has a screen fail rate of 520 divided by 1,520, so a third or a solid third, and try to talk about low-risk patients as somehow that being a real-world applicable study. The generalizability is just not there. So I think, yep, we've got a good system for intermediate to high-risk patients. Low risk, I don't like that terminology so much. But in terms of what's available for patients who are 70 years or older and over, this valve sort of offers the best potential solutions out of all the mainstream valves available from the large vendors.
Great. Maybe I can address the last question from the chat box to both of you. Are there any anatomies or critical situation where this valve, the Navitor, is not suitable, or you would prefer to use a different valve? Maybe we start with you, Dave.
Yeah, it's a really good question, isn't it? When do you not use the technology? The biggest reason why I don't use Navitor in my patients is currently the size matrix and the upper end of the size matrix for the Navitor valve. We know that with larger perimeters, larger areas, larger diameters, we have at the minute, in my experience, probably up to 1 in 5 of my patients have annuli that are too big for the current Navitor valve. So that's the biggest reason why I don't use Navitor in all of my patients. The good news on that front is that we are already studying the next generation larger size Navitor valve, which is called Titan. Clinical studies are underway. Australia are already ahead of the game in implanting cases in the trial. And so hopefully we will, in the near future, have availability of the Titan valve, which will be the larger size Navitor valve, to answer for me, the biggest reason why I do not use Navitor in all of my patients. Looking at my use of Navitor across patients, I think actually the Navisil technology has extended the use of Navitor across the spectrum of TAVI patients for me, really because of the paravalvular leak reduction in more complex calcified anatomies that we've been talking about. Clearly, as we do move into treating younger patients, that will raise the incidence of bicuspid valve disease. We have to be honest and say that there are no randomized data for any valve platform in bicuspid valves. And so with Navitor in bicuspid valves, we will need to learn and we will need to produce data for its usage in bicuspid disease. But I think that Navitor is ironically extending the population of patients that I think are treatable with a new technology across the spectrum of patients that I see.
Anthony?
Yeah, so I'll give a pretty honest answer to this one. Before Navitor, you'd always be a little bit in the back of your head, you know, because I came to believe in the paravalvular leak stuff being important a few years ago after a couple of cases of moderate PVL, and those patients, they struggle. Always in the back of your head was, you know, they'll get a nice seal with an S3 here and I won't have any paravalvular leak. And that was kind of in some cases where they had big access and I was happy to take a big S3 and do all that stuff. You felt a bit more confident. That one inkling of doubt is gone. Now with the Navitor, I've got the hemodynamics that you get are what you get with an S3 in terms of no paravalvular leak, but with no gradient, bigger effective orifice areas, smaller vascular access. And my experience has been the same in real world populations. The pacemaker rates, my highest pacemaker rates are with S3s. And I don't think that's because you know, I don't think it's an argument about the frequency of use. And I tend to implant my S3s high using a cusp overlay projection. It's because to circularize the annulus in real world patients, it's extremely traumatic to the annulus to turn what is always an ellipse into forcefully turn it to a circle and hold it there. And so the Navitor has perhaps, in my mind, extended the patient population. I was using Portico in most patients anyway, but the last kind of vestige was that, well, do I take the risk of a balloon expandable traumatic system because I know I'll have less paravalvular leak potentially? Well, this turns that on its head because we saw rates of paravalvular leak with this that were superior to what we see in real world populations with S3. And this was a high risk population and we didn't see any moderate paravalvular leak. It was mostly trivial or none, and 1 in 5 had mild. There was no moderate paravalvular leak. So this has turned all that on its head and really extended the patient population to basically all comers, except for that large size issue, which is being addressed.
Totally agree. I think the Navitor valves have been used for very calcified lesions, bicuspid aortic stenosis, patients with low coronary ostia, horizontal aorta, and even valve-in-valve anatomy. So basically, you can treat all sorts of anatomy, all sorts of annular size, and all sorts of annular anatomy. Great. We've answered all the questions in the chat box. So I think it leaves us with Professor Smith to give us the key learning messages.
Thanks very much, Michael. Yeah, well, I'd like to thank both yourself and Anthony for an excellent discussion. We've talked through how paravalvular leak impacts outcomes for our patients. And I think thanks to an excellent presentation from Anthony, it's very clear that we need to avoid this both for the short term as well as for the long-term well-being of our patients. We've also discussed the novel Navisil technology within the new Navitor system and how that helps to reduce and virtually obliterate paravalvular leak for our patients. We've seen a case and we've talked about how we can optimize procedures for our patients. And we've also touched on what I think is going to become increasingly important, as we've all alluded to, which is the lifetime considerations for our individual patients. And this is something I think that's going to be increasingly important as we look to treat patients who are perhaps younger than we've hitherto treated. So I'd like to thank my fellow speakers, Anthony Camullia, Michael Lee, and I'd like to thank you for listening and attending this webinar. Have a good day.
Good day.